Hello, my name is Oscar, and my topic for Module 2 in Clinical Practice 3 is Marfan syndrome. What is Marfan syndrome? It's an autosomal dominant hereditary disorder, which means that it can be passed down from parents genetically. And what it does is it affects the connective tissue. It can affect many different organ systems, and we're going to talk about those later on in the slideshow. 5% of sudden deaths in young athletes are caused by Marfan syndrome, and it affects about 1 in 5,000 people, so it is fairly rare. If one parent has Marfan syndrome, there's about a 50% chance that it's passed on to their children, but 25 to 35% of cases happen with no family history. People with Marfan syndrome are often tall and skinny with extra long limbs. As you can see in the photo on the right, this person has very long arms and legs, and their wingspan is what they're measuring is longer than their total height. Signs and symptoms of Marfan syndrome may present very differently for different people, so diagnosis is based on major signs of at least 2 different body systems. And we're going to go over the body systems in more depth further on, but the body systems that are affected include the skeletal system, cardiovascular system, pulmonary system, ocular system, and integumentary system. Because of all these systems and how it presents differently for everyone, it can be very difficult to diagnose. The signs and symptoms for the skeletal system include hypermobile joints, pectus excavatum, dental crowding, arm span to height ratio greater than 1.05, scoliosis, spondylolisthesis, positive wrist sign, and progressive collapse of the hind foot. If you look at my photos on the right, in the top left you see pectus excavatum, shown by the concave nature in the chest that almost looks like a dent. In the bottom left, just below that, you see the positive wrist sign, which shows when putting your thumb and index finger around your opposite wrist, there's an overlap. Like we talked about earlier, they tend to have long limbs and long fingers. The picture on the top right is the spondylolisthesis, which is when the vertebrae slips out of position. This time in that picture, it slipped anteriorly, and it also has some stress fracture reaction with it. And in the bottom right, we have the progressive collapse of the hind foot, which is that dropped arch. The signs and symptoms of the cardiovascular system are the most severe and most likely cause of death in people with Marfan syndrome, and they include the mitral valve prolapse, dilation of the pulmonary artery, descending thoracic aorta, or abdominal aorta, calcification of the mitral valve, dissection of the ascending aorta, and dilation of the ascending aorta. Those bottom two, the dissection and dilation of the ascending aorta, occur in 2/3 of cases and are very severe. If you look at my photos, the one on the top, you can see a dissecting aorta with the line coming in the middle of the aorta, splitting it, and not all of the blood is going out to the body. Dilation of the aorta is just the widening of that ascending aorta. My bottom photo shows mitral valve dysfunction, where there's regurgitation of blood not entering into the left ventricle or coming back into the left atria, so it's again not allowing blood back into the body, which can be problematic for patients. Signs and symptoms of the pulmonary system include spontaneous pneumothorax and apical blebs. Spontaneous pneumothorax is the sudden onset collapsed lung. You can see in the picture on the bottom left. Their left lung is collapsed in that picture, and it happens suddenly. The picture on the right shows apical blebs. That's when a small collection of air between the lung and the outer surface occur. In the picture you can see it's between the visceral pleura and the parietal pleura. Signs and symptoms of the ocular system include myopia, cornea plana, and lens dislocation. My photo on the bottom left shows myopia, also known as nearsightedness. My middle photo shows cornea plana, which is also known as a flat cornea, which you can see in the photo. And my photo on the right shows a dislocated lens. As you can see, it's not in the correct position. Signs and symptoms of the integumentary system include recurrent hernia, which you can see a photo of in the bottom left, striae atrophicae, which is also known as stretch marks, and you can see that photo in the middle, and widening dura in the spinal cord, which is most common in the lumbosacral region of the spine and is shown in the photo on the right. As athletic trainers, it's important for us to know when referral is warranted. As we mentioned earlier, Marfan syndrome can be very difficult to diagnose, so it can be undiagnosed in adolescents specifically. If we believe Marfan syndrome could be present, it's important for us to refer out for further testing. Another proper time to refer is if a diagnosed patient with Marfan syndrome has worsening symptoms. We should be referring that out as well. Additionally, unusual low energy or fatigue that could be due to decreased blood flow from the left ventricle or from the ascending aorta, or if the patient has unusual chest pain, which could be from the pectus excavatum that we talked about earlier. A few diagnostic tests that are often performed with Marfan syndrome include limb length measurements, which you can see a photo of in the bottom left, where that person is measuring their wingspan. Echocardiography, which is the combination of ultrasound, which views the chambers and the valves of the heart, and the electrodes that view electrical pathway of the heart. That you can see the photo of the ultrasound specifically in the middle. And additionally, there's MRIs, which you can see a photo of in the top right, which in this specific MRI, you see that it's dissection of the ascending aorta. The black line in the top shows no fluid there, meaning there's a mechanical dissection of that area. As there's such a range of symptoms for Marfan syndrome, there's a range of treatment as well. But especially for athletic trainers, monitoring symptoms is important, as if symptoms worsen, it could be due to dilation of the ascending aorta or any of the symptoms we talked about earlier. Continuous testing is also really important for patients with Marfan syndrome, as the disease progresses and needs further treatment. Additionally, there's prophylactic surgical intervention. A couple common ones are valve-sparing root replacement and total root replacements. As you can see a photo on the right, they put a synthetic graft in the ascending aorta to prevent further damage from the dilation or the dissection from that area. Beta blockers are also commonly used to reduce dilation of the ascending aorta. These are often used as preventative treatments. Lastly, there's lifestyle restrictions, as we don't want to put too much strain on the heart, and we'll talk about those a little bit more in the next slide. With Marfan syndrome, it's important to be thorough with our return to participation protocols. Echocardiographic evaluations should be done every 6 months to make sure that there isn't further dilation of the ascending aorta or dissection. Restricting high-intensity and collision sports is a lifestyle change that needs to be done to prevent further damage. High-intensity activities can put a lot of strain on the heart, and collision sports not only put strain on the heart, but on the musculoskeletal system. That does see a lot of symptomology. It's important to include non-competitive sports so they can stay active, but not putting too much stress on their body. And that there should be no signs of worsening symptomology if returning to activity. What I believe to be the role of the athletic trainer and what I plan to bring to my clinical practice if I see patients with Marfan syndrome is I'm going to be looking for signs and symptoms. As we know, this can be undiagnosed commonly in adolescents as symptoms appear. Also, if I do have a diagnosed patient with Marfan syndrome, I'm going to encourage regular testing, as I know their body is changing frequently throughout this disease in the course of this disease. Thirdly, I will find unique ways for safe participation, because I want them to feel included in the sports community and with the athletic trainers. A couple questions I have for the class are, would you allow an athlete with Marfan syndrome to play basketball if they are persistent? This is a tough one because basketball is a high-intensity sport and there's possibility for collision, but if a patient is persistent and really wants to play, how would you handle that situation? Another question I have is, what activities would you encourage an active patient who has Marfan syndrome? You have to try to think of a low-intensity sport with low risk of collision, but they can still be somewhat physically active and have fun with. A few options I have thought of are bowling or bocce ball, but I know there's so many more. Thank you for listening, and here are my references from this PowerPoint presentation.